Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in our Conversation with Cancer Experts series, we have Dr. Forat Lutfi, who is assistant professor at Kansas University Medical Center in the Heme Malignancy and Cellular Therapeutics division. And he's going to talk to us about a couple of key abstracts that were presented in the lymphoma session at the ASCO meeting held in July in Chicago. So welcome, Forat.
Thank you. Thank you very much, Ravi.
So we're going to talk about, first Lisocel for diffuse large B-cell lymphoma and then for mantle cell lymphoma. So can you tell us about the trial, the Transform study, and its presentation at the ASCO meeting? First of all, we'll just start off with the trial design for those that are not familiar with this, and then we'll delve into the data.
So this is really one of the kind of landmark studies in the follow-up here, looking at patients who have what we call kind of second-line use of CAR T therapy for B non-Hodgkin's lymphoma. And so this was looking at adult patients with the aggressive histologies of diffuse large B-cell lymphoma, transformed large B-cell lymphoma, as well as your kind of double and triple hit high-grade lymphoma, grade 3B follicular lymphoma, as well as some other types. And so the population here was essentially those who had what we call primary refractory disease, or those who had early relapse less than 12 months out from initial therapy. And this was in patients who received had anthracycline and CD20 targeted therapies, which is the kind of standard of care frontline treatment in this day and age. And these were patients who had functional status ECOG of 0 or 1, and patients who were deemed to be eligible for stem cell transplant. And so essentially, patients were screened at time of apheresis. They did a 1-to-1 randomization here with 92 patients in each arm. Of note, bridging therapy was permitted in this study. And in the patients who were randomized to get CAR T, they received standard fludarabine cyclophosphamide lymphodepletion, followed by Lisocel infusion within 2 to 7 days of lymphodepleting chemotherapy. And then they did the disease assessment here, which was done up to 36 months after randomization. And interestingly, in a point here is the vast majority, 97% of patients actually did end up receiving the CAR T product, which is something I think that is important to note. A lot of times, we do worry about patients who you have the intention to treat and you're unable to actually get them the CAR T, but in this, nearly all patients were able to get the CAR T therapy. Looking at the standard of care arm, these patients got what previously was the standard of care for the last 3 decades, which is giving patients salvage chemotherapy for 3 cycles or so, followed by high-dose chemotherapy and autologous stem cell transplant. Of note here, less than half of patients received the autologous transplant, and that's something that we commonly see here. And also of note, over half, 62% of patients in the standard of care arm received Lisocel, and in crossover. Essentially, those are the patients who are not responding to salvage chemotherapy. And the primary endpoints here were looking at event-free survival and some secondary endpoints as well.
So what did they?
Looking here at
yeah. You go ahead. What was the primary endpoint readout like?
Yeah, so looking at the primary endpoint here with event-free survival, which I think is a really nice way. I like that this was the primary endpoint here, because I think it gives you a richer understanding of what you're looking at in the patients here. So it's patients who are still alive, patients who have not relapsed, and patients who have not received other therapy. And so that, I think, is a really good kind of composite way to think about things. And so here, looking at that event-free survival by the independent review committee, you see here that the median follow-up is at 34 months. You see quite a significant difference here in the event-free survival arm versus standard of care. I mean, 46% versus 19%. Very, very clear separation of the curves here with the stratified hazard ratio of 0.37. I mean, this is a really remarkable finding.
And so what about depth of response and duration of response data?
Yeah, so I mean, this also just kind of continues that story here. I mean, you're seeing an overall response here pushing close to 90% in the Lisocel arm versus just under 50% of the standard of care arm. And the overwhelming majority of these patients in the Lisocel arm are achieving a complete response, which is really quite remarkable here at 74% of patients compared to about 43% in the standard of care arm. And I think it's important too, historically, when you think about Scholar 1 and the Parma studies, that these patients, generally speaking, standard of care with high chemo, autologous transplant, long-term survival in these folks is well under 30%. So even here, the standard of care is actually somewhat better than what's historically been expected. But nonetheless, I mean, still a remarkable difference here is the CR rate between Lisocel and the standard of care arm. And I think that we see here that the differences in the responses are quite durable. At almost 34 months median follow-up here, we see that in the Lisocel arm, the median response is not reached yet, while it's a mere 9.1 months in the standard of care arm, and the 24-month duration of response rate is 60% in the Lisocel arm versus 43% in the standard of care arm, with the stratified hazard ratio of 0.6. I mean, so this again is quite remarkable and really supports the use of Lisocel in this setting.
And what else can you tell us about survival?
And so looking here at progression-free survival, it kind of, I think, tells a similar story where we see that the 36-month progression-free survival rate here is 51% in Lisocel and basically half of that, 26.5% in the standard of care arm. We see that the median is not reached in the Lisocel arm and is a mere 6.2 months. And again, that's pretty consistent, I think, with what we've seen historically with the standard of care in this setting. And you also see, I think, a further separation here in overall survival. So the overall survival is not quite as, dramatic, I think, as looking at PFS and kind of the other measurements that we've just discussed. But I think it's important to remember that, again, 60+% of patients in the standard of care arm ended up receiving the Lisocel, ended up receiving CAR T therapy. And so, I think that may certainly account for some of the difference here that we're seeing, in survival and the curves not being quite as dramatically far apart as one would otherwise expect.
And what can you tell us about the CRS and neurological toxicity that often characterize CAR T cell therapy and other side effects like
Yeah, absolutely. And this is always one of the biggest concerns that we have. And I think in general, what we see here is consistent with what we expect for Lisocel as a 4-1BB product and having, kind of a more acceptable or rather tolerable incidence of CRS and neurotoxicity. So regarding, cytokine release syndrome, which, is essentially, I describe it to patients as being like a really bad flu. Grade 1 is 37%, grade 2, 11%, only one patient with grade 3. So while, about half of patients experienced CRS, it was almost all grade 1 and really very little high grade CRS here, just with that one patient. And so that's really reassuring, and no grade 4 or 5 events. As far as neurologic events, again, no grade 4 or 5 events. Overall, very low grade, 11% of patients, having neurotoxicity. That's also very reassuring. And then looking at management here, it's kind of what we would expect with CRS and other, kind of neurologic events here, using either corticosteroids alone or a combination of tocilizumab and corticosteroids in a very, small number here. Same with, CRS and, of course, neurotoxicity alone being managed with corticosteroids. But we're talking only about, a quarter of patients here actually needing treatment, with tocilizumab or steroids. Is really, I think, quite remarkable and shows how safe this product can be in this setting. Now, in regards to cytopenias, and this is defined as grade 3 or higher cytopenias here at 35 days out, which I think is an important time point because almost everybody is going to get the initial cytopenias from the lymphodepleting chemotherapy. But we hope to see some recovery here, and I think day 35 is a really good time point to kind of see where cytopenias are at. And so, with Lisocel, about 43% of patients ended up having this grade 3 or higher cytopenias, and it was significantly less in the standard of care arm. And that's, I think kind of expected here. I think by day 35, most patients in the standard of care arm who received autologous transplant would have engraftment and recovery of their counts. Regarding infections here, they were quite comparable in this study. So as far as grade 3 or higher infections go, 15% in the Lisocel arm and a slightly higher 21% in the standard of care arm. And I think more broadly speaking, and looking at other studies, particularly kind of retrospective registry studies looking at CAR T, this is, I think, pretty consistent as far as infections go. Perhaps a little bit higher in the standard of care arm than we would think with autologous transplant, but again, less than half of patients got transplant, and as we said, 62% got crossover to CAR T. So I don't really interpret that aspect of this. Wouldn't put too much into that. But overall, I take the takeaway here. I think is that this is, Lisocel is a very safe product and very manageable with very little high-grade toxicities.
And what can you tell us about the persistence of these cells long term?
So, I think Lisocel, again, is a 4-1BB co-stimulatory product. We know is that kind of promotes greater persistence than the co-stimulatory products, and so I think this kind of tells that story, and that we see even just after day 30, 90+% of patients have persistent Lisocel detected here in the blood using the ddPCR. And that the number of patients, even at almost 3 years out, about a quarter of patients still have detectable CARs, continuing that immune surveillance. And I think that is exactly what you want to see. Regarding B-cell aplasia, I think it's important to note even prior to CAR T, 80% of patients here had B-cell aplasia. So these are people who are kind of reeling in from being treated with chemoimmunotherapy. But at day basically 36 on that first CAR T assessment, and all the way through, really looks like up to day 126, almost all these patients have B-cell aplasia, which is again consistent with what we expect to see with persistent CARs. And then what we hope to see, in my clinical practice, I tell patients between about 6 months, really up to 12 months, I like to start seeing some B-cell recovery, but of course, there will be many patients who will have B-cell aplasia virtually indefinitely. And that's what's seen in this trial, and what this, is showing here, that even at the 36-month mark, about a third of patients still have B-cell aplasia. And of course, that, can be contributory to particularly sinopulmonary infections and just the risk for infections in general, and often require patients to, receive intravenous immunoglobulin. But yeah, overall, I think this shows that you have cells that are there that are persisting. That's quite reassuring.
So another abstract was on the utility of this very CAR T Lisocel in mantle cell, and since that time, the drug has also been approved for this indication as well. So it's let's talk about the trial here with Lisocel and mantle cell. So what can you tell us about this trial design?
Yes, I think everybody was really excited to see this and have the recent FDA approval and to have another CAR T option for mantle cell lymphoma. And so, kind of key highlights here as far as the eligibility goes. This was adult patients, patients who had confirmed mantle cell lymphoma with detectable disease, with the exception of, I think, only 2 or 3 patients. These patients all had received 2 or more lines of prior systemic therapy. including a Bruton's tyrosine kinase inhibitor, an alkylating agent, and a CD20 targeted agent. These were patients who had good functional status, ECOG of 0 or 1. And interestingly, patients who had secondary CNS lymphoma or prior autologous or allogeneic stem cell transplant were eligible. And of course, patients had to have adequate organ function, cardiac function, et cetera. So, this was a single-arm study here. And so patients were screened, and, if they met screening, they had Lisocel manufacturing. Bridging therapy was permitted in this study as well. And following, leukapheresis and manufacture plus or minus bridging, patients underwent standard fludarabine cyclophosphamide lymphodepletion for 3 days, followed by Lisocel infusion 2 to 7 days after, with the first disease assessment at day 29, and follow-up of 24 months. So there were 2 doses here. There was a dose level 1, which only 6 patients received, and that was 50 million CAR T cells. And then there was a dose level 2 of 100 million cells, which is what most patients received. And this is what was used for the dose expansion cohort. Primary, we're looking at safety and overall response, which was based on Lugano criteria by an independent review committee. And of course, secondary endpoints here looking at complete response rate, duration of response, PFS, overall survival, and then looking at kinetics as well.
So what would you like to point out in the demographics of the patients accrued to this study?
So I think it's, looking at this, what I think really stood out to me were a couple of things. The first here, is just, this is a very refractory population, with, 69% of patients here having, refractory disease. And then the other thing is, this is a very heavily treated population as well, where, you had 77% of patients here, or rather 26 out of the 88, had gotten 5 to 11 lines of therapy. The other thing I think here also is that you had a population here that had been refractory to BTK. You're looking at almost half of the patients here were refractory to a BTK. And so, this is kind of the mainstay of what we have for treatment in folks who don't respond to initial chemoimmunotherapy. And looking at here at patients who had the best response to any prior therapy, you had most of these patients had achieved a CR at some point, and so you're dealing with a population that's relapsed after having initially a nice response. And the other thing here is looking at the median time from diagnosis to receiving Lisocel infusion, and you see here that the median time there is almost 5 years. So these are people who have been living with mantle cell lymphoma for quite some time. And looking at the BTK inhibitors, I think it's good to see that you had quite a few patients who, received BTK inhibitors. All of the covalent, are included here, and you even had 6 patients who had received prior, non-covalent pirtobrutinib, which I think is important and has real-world applications when we think about applying the trial to our patient population.
And so what were the responses like?
They're really quite remarkable here. So, as we just saw, this is a population of patients with mantle cell lymphoma who've been living with the disease for some time, who have been treated with very good therapies and quite a number of therapies in many cases. And despite that, you achieved an overall response rate here of 83% with a CR rate here of 72%. And that's based on, looking at a number of lines of therapy. And as we see, even in patients who have received 5 to 11 lines of therapy, the response rates were quite similar. And then looking at, patients who had previous response to BTK inhibitor, even in patients who are refractory, you still had a pretty good response here. Overall response rate of 76% and a CR rate of 64%. Obviously, these patients who were refractory to BTK, certainly did not quite do as well, which is expected. But nonetheless, I still think it's a positive to see that there was still that degree of response. And of note here in the,
Sorry, I'll go back. Sorry.
It's okay. I was just going to comment here on the point here that in the 3 patients who were included here had the only 1 prior line of therapy. Those patients had a great response, and the 2 who were able to be evaluated, they had complete response as well.
So what can you tell us about the tolerability of this approach?
Yeah, so in the treatment emergent adverse events here, looking at CRS and neurotoxicity, and this is kind of consistent with what we see with Lisocel across the subgroups. A very well tolerated product. Of note with CRS, it was almost exclusively low grade, grade 1, 2, and that was seen kind of across the board here, regardless of number of lines of previous therapy, and regardless of previous response to BTK inhibitor. Perhaps slightly more, CRS seen in comparing the BTK inhibitors, but I wouldn't say really very significant. And then looking at neurologic events here, they were, I would say, low grade. It looks like, no grade 5 events, a handful of grade 3 and 4 events, but, the vast majority were low grade 1 to 2 neurotoxicity, which again, I think is quite manageable. In regards to prolonged cytopenias, this across the board was seen in about 40% of patients. And I think surprisingly here, in comparing the number of lines of therapy, certainly a bit higher prolonged cytopenias in those who had previous, more therapies in the past of 5 to 11 lines versus those who had less, which again, I think is expected here. And then, quite comparable otherwise in those who are BTK refractory, perhaps again, slightly higher prolonged cytopenias. Infections, though, across the board were quite low and I think comparable, and very little tumor lysis syndrome was seen. And so my takeaway from this is that I think that consistent with what we've seen across the board with Lisocel, I think this is a very safe product.
And so what about, again, here in terms of the kinetics? What can you tell us about that?
Yes, this I think is a very interesting slide, and it makes a lot of sense. So these products are expanding quite nicely, and we see here in the overall population at the number of copies here, the Cmax, that in those who are having less lines of therapy, they had good expansion. In those who had 5 to 11 lines of therapy, the expansion was less. And in those who had refractory disease refractory to BTK inhibitors, the expansion was less as well. And I think that makes a lot of sense. I mean, these are patients with each line of therapy, and this is something that's applicable to all autologous CAR T products. You are getting the fitness of your T cells are going to decline. All of these cytotoxic chemotherapies and even the targeted agents can have a deleterious effect on the T cells. And so I'm not surprised at all to see in those that are more heavily pretreated that your expansion was less. Looking at as far as the time to maximal expansion, 10 days, it looks like that's across the board, again, consistent with the 4-1BB co-stimulatory receptor product. And then looking at the area under the curve here, again, consistent with what we were just talking about here, looking at the Cmax, for those who had been more heavily pretreated and those who were refractory to BTK inhibitors were having less AUC. And so that's, I think, again, what we expect to see, and a good reason and rationale for trying to use CAR T products sooner rather than later.
So now, how do you use Lisocel? First of all, let's talk about diffuse large B-cell lymphoma. And where do you see Lisocel fitting into your treatment of diffuse large B-cell lymphoma?
I think that, again, Lisocel is a very good product. I use it. It's not the most frequent product that I use, but I would say that I do use it quite often. I think the patient subset where I really think about using Lisocel, say, over Axicel, obviously in the second line setting here, talking about primary refractory or early relapse, those are the only two options currently available, given that T-cell had a negative study with Belinda. If patients are older, more frail, or say higher bulk, and there are, which can suggest a higher risk for cytokine release or neurotoxicity, or otherwise could not handle the toxicities that come with CAR T therapy, then I would use Lisocel in that patient population for DLBCL. If I have very young, fit patients, I don't have a lot of time, I need a product as soon as possible, I'm less likely to use Lisocel, and I would use Axicel in that setting.
That is, I guess, driven by the shorter vein-to-vein time for Axicel?
Yes, and as of late, it's narrowed a bit, but I would say I still can get Axicel probably about a week faster than I can Lisocel. I think the time has gone down a bit in the last few months with getting Lisocel, but it's still, I think, about a week longer.
Do you do any outpatient CAR Ts yet?
We've done a couple, and so that's a very good point, actually. And so the few that we've done for DLBCL have been, Lisocel predominantly. And I think as we make that transition to outpatient, I think the 4-1BB costimulatory products like Lisocel and T-cell are going to be much more kind of advantageous in that setting. And I know that other centers have made that move to doing outpatient, sooner than we have, and I think that is a big advantage of Lisocel.
That is predominantly because of the lower risk of grade 3-4 CRS and neurotoxicity, and I presume also because of the delayed onset that is favorable for outpatient administration.
Absolutely. I think that grade 1 toxicities can be managed very easily. And so, if we compare in general, the 4-1BB products, always keeping in mind the dangers of cross-trial comparisons, certainly the incidence of CRS and neurotoxicity is less, and the overall incidence as well as the incidence of high grade. Grade 1 toxicities can be managed fine outpatient. Grade 3 and grade 4 cannot. If a patient is getting hypotensive and hypoxic at home, we're in serious trouble. And so that is a big reason why I think as centers are moving more towards outpatient 4-1BB products, I think like Lisocel will likely be more commonly than they perhaps are right now.
What about mantle cell? Where do you see the use of Lisocel for your mantle cell patients? Which line of therapy?
So I think that, we just got FDA approval, I think, on May 30th. And so I have not had the pleasure yet of giving Lisocel for mantle cell lymphoma, although I'm sure in the coming weeks and months we will have our first patient here. But I feel great about that, actually, because, while what we've had, now with Brexucel, it's a wonderful product. It is very, very toxic, and so there are a number of patients with mantle cell lymphoma who I don't think can handle or tolerate the Brexucel. And so having Lisocel now with this FDA-approved label, which is, more or less the same here, greater than 2 lines of therapy with previous BTK exposure, I think is going to open up the ability to give CAR T to a lot of patients that we otherwise could not give CAR T to. So I'm very excited that we have that indication now.
And in terms of persistence of CAR Ts, what is your take on the need for persistence for efficacy? Does that always greater persistence translate into greater efficacy? Is it, that in different disease states, there may be a different need for persistence?
Yeah, I think this is a really important point of discussion. I think there's a lot of debate. I think this is absolutely the million-dollar question. So I think it's a combination of factors. So, I think for B-ALL, I think beyond any doubt, persistence is important for ongoing response and for long-term, especially in patients who are not going to be getting an allogeneic bone marrow transplant. I don't think there's really any room for debate there. For lymphoma and for myeloma, I think people perhaps could debate it. I will say my personal opinion is, and I think there are studies that one can find that are in favor of, and others that say it's not as important. But again, in my personal opinion, I think that persistence is very important. I think it is one of the important keys for efficacy, and I think one of the many mechanisms of escape in lymphoma and myeloma, other than obviously the antigen escape, is persistence and exhaustion. I think those are very important. I think in patients who are not having persistence of CAR T cells, I think those are the people that I worry about relapsing early. And so I think it's really important. And what I would also say is, and those who would disagree, I guess, with that in lymphoma, that persistence is not as important, especially if you're getting an early CR, at day 30. Some would argue, well, why do you need persistence of patients in complete remission? I would argue that persistence and ongoing immune surveillance is very important to avoid having a relapse. And why I think it's important to see that is looking at allogeneic products, right? So we see with many allogeneic products, they have early expansion, but one of the big issues with allogeneic products that we've been trying to deal with is their persistence. And I think we see that because of that lack of persistence, there are concerns about long-term efficacy. And so I think that, as time goes on, I think we'll see more and more evidence that efficacy is really tied very much so to initial expansion and persistence.
This product also now is approved for use in follicular lymphoma, I believe, as well. So
yes.
That data. Well, I want to really thank you very much for taking the time to educate the audience about Lisocel and the updates from ASCO on diffuse large B-cell lymphoma and mantle cell lymphoma. I hope I can draw on you at a future program to talk to us about other topics of interest as well.
Absolutely. Thank you so much, Ravi, for your time, and really enjoyed discussing these new findings and the updates here on Lisocel. We're always very excited about any new indications and any new data coming out for cellular therapies.
Thank you very much.